Welcome, everybody. Today we're discussing eHealth or telehealth, which is the latest trend now, even here in the US. A couple of weeks ago, I wasn't feeling well, and I had my primary care physician on the phone with me. It was literally done it was my first time having a full, I don't know who needs to mute. Okay, let me, let me mute you guys. Yeah, so what happened is that it was my first full consultation with a physician over on video, and I really was very skeptical about it, but it worked out very well. And yesterday I had all the tests, and fortunately everything is good. But if there's anything that the pandemic has taught us, that telemedicine or digital medicine is an option for everybody, and particularly in Africa, we have a challenge in healthcare delivery. So we can scale up our delivery basically by using telehealth. So Nomhle, I know you're working with a telehealth organization in Zimbabwe. So I would like you to just go over your relationship with this company. And I think you have a couple of organizations with that are setting up telehealth in Zimbabwe. There's been a pilot project that Professor Yunka, hopefully who will be joining us, has run in the Eastern Highlands in Zimbabwe, and it's been successful, and they're going to scale it up soon, hopefully with Dr. Skipper's company. So he'll go in and discuss that at length as well. So go ahead, Nomhle.
So basically what we have... Am I muted? Can you hear me?
No, you're not muted. Yeah, I can hear you. Yeah.
Okay, great.
You're definitely live. Go.
Yeah. All right. Yeah. So I did a bit of work. I think you were part of it with Future Med and Dr. Omar. But she has unfortunately left the country. We had 23 sites that we were given that we were planning to implement this telemedicine and just connect to a number of doctors that we had agreed to work with. And yet at the same time, there is an NGO here in Zimbabwe that's been in touch with a number of the district council clinics and hospitals. They fund some of these projects. This is pre-COVID, so we're trying to figure out, the way forward now, and we're just looking for partners. If you already have the technology to roll out, but otherwise systems like Connected Health with Cisco are not that cheap, and we need systems that are easy to deploy, and then we'll work out the rest of the administrative costs from an NGO perspective. So basically, the plan will be to work with the existing infrastructure. Mm-hmm. They don't have the money to roll this kind of system out. So if an NGO comes and they've got funding, then it makes it easier. And we'll be using the team that they already have in place. We pay for the training, we pay for the technology, and then either hook them up with whichever doctors are available.
Well, I've set up a nonprofit, obviously, in Washington, D.C. to support healthcare in Zimbabwe. Our registration process should be done by year end, and then we can get some donor funding, and we'll be able to work together on that level. But I believe there's a business being set up on a more for-profit level. Dr. Sakipa, can you give us a little more insight on what your company does? And I believe you are partnering with Telenet Health, the Swiss-based organization that's focusing on eHealth.
Okay, Debbie, I'll be happy to do that. Am I muted? Can you hear me?
Yeah, we can hear you.
Okay, all right. Okay, just a bit about the Compre Health Services. Compre Health Services is a private health company that's...
sorry, Doc, can you center yourself on your camera so we can see your whole face there? There
that
you
better?
go. Yeah, that's better. We see your handsome
Okay.
face.
Yeah. Then you want to see this handsome face. Okay. So, so I was saying that Compre Health Services is a private health consulting company that's based in Zimbabwe. We have been operating since 2012. Our main thrust of work has been providing technical assistance to Ministry of Health and some development partners, including WHO, UNICEF, World Bank, and others. While the trust has been providing this consulting work, one arm of Compre Health seeks to provide actual patient or medical services to people in Zimbabwe. So far, we haven't gone into that aspect yet. We were involved in a project which was funded by USAID, in which we provided training and technical support and logistic support to private medical practitioners and nurse practitioners in various parts of Zimbabwe with funding from USAID. This was meant to beef up the capacity of these private providers to provide prevention of mother-to-child transmission, PMTCT. So we did that a couple of years back. So I guess that has exposed us to how the private sector operates. So the way I see this potential project is that, number one, there's great need out there. Even though we are in a universal health coverage era, we are still far from being able to provide universal health coverage. So I believe that telemedicine opens up the potential or the possibility of expanding services to many people that are currently not covered. Let me give a practical example. We have health facilities, rural health centers, and clinics that are open, that are owned by district councils and the municipal health councils. And these do not have easy access to doctors. So it is then possible for telemedicine to provide the possibility of a woman sitting in Binga at a health center being able to access the services or the advice of a doctor sitting in Harare, in Karoi, in Nyanga. So I look at this as a great potential for us to quickly expand services to many people, particularly disadvantaged people in the country. I believe that we have the option of working with various healthcare providers, including government, including industrial or mining clinics, as well as private sector entities, and also even mission hospital facilities. So I am eager to participate and work with others on this. The one thing that I know already is that we have a lot of initiatives that are already in the country, initiated by various people, including some doctors that are working in district hospitals and others that are working in the private sector. So it would be nice to see what's on the ground already and build on that instead of starting afresh. So I think there's lots of potential. We can achieve a lot in a very short time. And the good news that is the policy environment is also great. Zimbabwe has invited public-private partnerships, and there are policies that govern public-private partnerships. But what is not there are the modalities of implementing these things. So this is, I think, what we could bring in terms of getting things done, how to operate within the confines of existing system, working with the district health executive, working with the provincial health executive and the Ministry of Health.
Awesome. So let's just pivot a little bit. Dr. Sitipa, you were permanent secretary of health in Zimbabwe. I don't know how many years were you perm sec? Which years?
Oh my God. 1990, I left 92 to go international. So I've been working out of Zimbabwe, but have remained very much connected with the system. More recently, I was actually the chairman of the Health Paranatal Hospital Board. So, and I've been, yeah, and about a year or so ago, I was contracted by UNICEF to work with the Ministry of Health to develop the first ever community health strategy for the country.
So, Doc, if there's anyone who knows what Zimbabwe needs right now, it's you. You know, this is one of my many attempts to try and talk to doctors and to the community to see what does Zimbabwe need right now. We need to upgrade our primary healthcare facilities, and we need equipment, we need more clinics, and my effort to even start the nonprofit is to go out there and get even old equipment that hospitals in Europe and the US are disposing of, we refurbish them, and we get donors to pay for shipping and get things to Zimbabwe. We're following the WHO guidelines for all that. But Zimbabwe's needs are many. What are the first points that we can address right now to get Zimbabwe's healthcare to where it was at least to 1980? We're not even thinking about getting to 2020 levels, but getting it back to what it was. What can we all do to get Zimbabwe's healthcare back there?
Yeah, I guess the first thing is a realization that despite the very challenging environment that exists now in terms of funding, I do believe that we have a fairly solid system in place that is well structured from the national level right down to the community level. What is needed is to infuse the possibility or the advantages that can come with telemedicine into this existing system and properly synchronize it with the system that's working on the ground already, especially if we focus, for instance, on the district level. I believe it is important for us to be able to work with the district medical officer and his or her team at that level, so that the telemedicine that we're talking about can be placed at rural health centers, which are government-owned, clinics that are local authority-owned, and possibly even private sector where we have mines like Platinum, Zimplats, and others that are operating there. So we say, guys, this is what we can do to make things work better for us to expand services closer to the people. And I should also quickly add that it will also be important for us to be able to work with the existing structures at the community level, the socio-political structures, village health committees, ward health committees, and we capacitate them to be able to look at what are their health needs, what is it that they can do, what assistance do they need, and we facilitate regular interactions with them.
Okay. So in the last month, I've had 3 relatives die in Zimbabwe. Nomhle, you are in Zimbabwe. There's a lot of complaints regarding like hospitals are not available. You know, people go from hospital to hospital trying to get their relatives admitted, and then the hospitals are asking for huge amounts of money. What is going on?
I mean, it's really, really bad. We have also lost quite a number of people here in Zimbabwe, and everyone who is in my network, people are dying, and it's not all COVID related, but it's just not that easy anymore to get admitted. There's complications at Parenyatwa because it's obviously designated at national level or at Harare level for first COVID cases. But before you're admitted, you've got to have your COVID test done, and it takes 3 days to get the results before you're admitted. And in those 3 days, we're having people just dying just like that. And the private hospitals, you still need to have your COVID test done, but it's pricey. Not everybody can afford that. And then you start looking at the medical health solutions that are there. People cannot pay those monthly premiums either. So you can tell that the majority of Zimbabweans, they cannot afford to get any medical attention whatsoever. I mean, the rest of us have to pay in US dollars in order to be able to get any cover. And even then, you still get shortfalls.
Right.
Mm-hmm.
Yeah. And I don't even go to the doctor. I go for my annual checkups. And when I go, it's because, well, I'm thinking, okay, maybe let me use a doctor instead of just because I'm paying a service which I hardly ever use.
Yeah.
Okay.
Yeah.
Can I jump in, Debbie?
Sure.
Debbie, I think there are two issues, and we maybe need to separate them. We have the current one, COVID, which has come in and made an existing difficult situation worse. So perhaps we need to go back before COVID. What was the system like? It was already weak and almost dysfunctional, in the sense that even if you went to a hospital, you managed to see a doctor, you managed to have a diagnosis, you'd still probably not have any medication or you have any tests done in order to make the full diagnosis. So COVID has just made an existing bad situation, and that bad situation is because of inadequate funding, because of all the issues that we have had with health manpower, the constant strikes, and these are things that need to be resolved at national level, at political level, at economic level. But in order to address that, I guess we now just have to accept that perhaps government alone will not be able to resolve these things. There needs to be a very strong element of public-private partnerships, but this has not moved fast enough or well enough from the policy level into actual implementation. I think we now need to translate the stated policies into action. So I do believe that if this initiative can come to fruition, it will be timely in the sense that it's desperately needed and urgently needed. And also we can hopefully work with government and others, mission hospitals and local authorities, to be able to address some of the immediate issues. And there's willingness. I've had discussions with Seat of Harare and some district councils that are saying, yes, we are willing to do these things. The challenge has been finding potential funders that are able to inject funds into the system, but the willingness is there.
So the United Nations has designated health and wellness as the Sustainable Development Goal number 3. Even the UN recognizes that there's no government that's going to pay for all the health needs that the world has right now. So the key thing is partnerships. The vision I have for my nonprofit is to partner with tech companies. You can go to your Googles and Facebooks and whatever and see what they can do for Africa. I mean, they're already making their money from Africa as well. and partner with them and see what we can do from the technology point of view. And then you go to your device manufacturers, right? So you go to your laptops, your tablets, and donate them for our nurses, for our doctors, for our students to make sure we have all that going on. Oh, we've got Dr. Sachikonye joining us. Hello, hi, Doc.
Hello, can you hear me?
Yes, we can hear you. How are you?
Very well, thanks. How are you? Let me just set myself up.
Okay.
I'd asked Cindy to join us as well.
Okay.
But I don't think she was able to. So hopefully next time she'll be able to join us.
Yeah.
Yeah, Debbie. Quick point of. Where is Dr. Sachikonye, and what are the? It might be useful to know how to.
Okay.
To them.
Yeah.
Okay. I'll give a talk about who I am or what I am. I'm Nomhle Mujakachi. I come with almost 20 years experience in the IT sector, having worked for companies like CompuWare Corporation. It's a company based in Detroit, Michigan. And then I worked for SAP, the German company doing ERP solutions. So from your business intelligence to healthcare solutions, or having customers like Mediclinic, Netcare, and some government hospitals, not only in South Africa, but in different countries. I worked across Europe, Middle East, as well as Africa region. I work for Cisco Systems. Cisco Systems has a solution called Connected Health. It basically works like telemedicine, but uses high video technology, connected to the phone, connected to your internet, and all the equipment that the doctors and nurses will be using on site. So it's the same. It competes with telemedicine, and any other company that does that. And I also worked for Software AG. Basically, it bridges the two together, the SAP enterprise solution side as well as the hardware side, because they form integration solutions to connect to your third partners. For instance, if you look at the healthcare solution that Rwanda has, they've got a healthcare solution that collects all the patient information, and then it makes it available to doctors, makes it available to the healthcare insurance suppliers, makes it available to your dispensary, like for medicines, your pharmacies, etc. So everything becomes integrated, and then it starts on your phone. So that process design and then process automation is what we used to do at Software AG, where the user can use their mobile or any device that they want to use. They request for a service, they can see what time they can see a doctor, next available slot, they book it, confirm it, and it tells them which ones. So it's using geolocation services. A very nice integrated approach. So that's where I come from. Although,
where are you based now, Nomhle?
I'm now based in Harare. I run my own bespoke ICT consulting company, and I also run a renewable energy company. I do consulting services for people with big projects that want to do utility scale. So anything from 1 megawatt going up. I also do home installations for solar farms, etc. Yeah.
And Debbie, Dr. Sachikonye perhaps can tell us.
Yes, yeah. Hi, Doc.
Hi, how are you doing?
Good, how are you?
Good. Good to see you all, guys. Okay, my name is Mordecai Sachikonye. I'm a general surgeon. I have been practicing in Harare at Harare Hospital since 1997 as a junior doctor, and then started practicing as a specialist in 2008. I also do private work. I'm also involved in teaching, both at the university and we also go around the districts, just trying to disseminate basic surgical skills to the district doctors, so that, if you're on the highway, if you're in the remote place, that the doctors there have the basic emergency and surgical skills. Of course, we haven't been able to do that for a while because of the COVID. I'm interested in what Nomhle was talking about regarding alternatives to telemedicine, because surely at this time it's something that needs to be worked at, even for operative disciplines like mine. We, to a certain extent, use technology in that my junior doctors at the hospital can send me pictures of images, and we can discuss online. Of course, there are issues with connectivity at our government hospitals. I mean, there's no Wi-Fi at the moment. I understand that someone is trying to offer Wi-Fi, but it's clearly something that we need to have, so that connectivity is easier, and we can even communicate with the hospitals that are referring patients to us before they send the patients. That's who I am.
Awesome. And just for the sake of disclosure, Mordecai and I are family.
Sorry?
Mordecai and I are family. He's married to my cousin, my first cousin.
Total corruption.
Okay, and then further disclosure. Whose cousin I went to school with? We were in the same class during O-level with Chido.
Oh, really?
Yeah, Chido Mhlanga. And then obviously I've known Debbie since. Yeah.
Okay.
Since
So
we were kids.
apparently, Dr. Skipper and I were neighbors in Gun Hill, but we only met recently here. He lives here in Virginia, in the DC area, and but I did not know him when he was at PermSec of Health.
Debbie, okay. You say I live here in DC. Actually, I'm not sure where exactly I live, whether in DC or in Harare. So, but yeah, mostly I spent quite a bit of time in both places. It seems then, from what I hear from Dr. Sachibonye and Nomhle, the potential is right there, and I think we are what we need at this stage is to get started. Let's find a mechanism. Let's find a framework for putting things into operation, because there's a lot going on already that we can build on. So what's needed is to demonstrate functionality at the operational level, and then this can be expanded. Maybe we could focus on, say, one district and say, let's adopt one district. We go to a district hospital where there is some operations with the surgeons, with the obstetricians, and then that district with the DHE is linking with some primary care facilities in the district, and we can infuse telemedicine where we can do training and actual patient consultation.
Okay, so can I sort of ask all of us to discuss, apart from telemedicine, what are the solutions that Zimbabwe needs? I know power is an issue, internet access is an issue. Those are really sophisticated solutions, but if you're in the village somewhere where there's no power, what is it that Zimbabwe needs immediately? The reason why I chose to come to DC and to try and look for money, my job now is to go and look for money, right? If I approach a foundation or a donor, what is the conversation I'm going to have with them? What are the first needs that we have? What is the ask? Because in a few months, I'll be fully set up for accepting donations. But once the money comes in, where does it go? That's usually the biggest challenge, is the implementation. People don't trust that if you give money to Africa or to an African, that money will get to where it's needed. So I worked with a nonprofit when I first came to DC, and they're doing healthcare in Africa. And they were given a lot of money, millions, but all the money goes on admin and other expenses in the US, and nothing goes to Africa. And that's the type of thing I'm trying to avoid. I want to be the voice where we can try and raise money for Zimbabwe, make sure that money goes there. When it arrives there, I spoke to a few local doctors in the US, they're Zimbabwean doctors, and they say that they helped during Hurricane Idai, but then the money was misappropriated. So what is the system in place where we can make sure that doctors, if they need to build a clinic, nurses, if they need to build a clinic, they'll be able to get that money?
Just a quick response. First of all, the districts are not uniform. They are different. You can go to one district.
Oh, hello, Doc?
There is a district hospital which is well connected, and you can go to a district where there are health facilities, rural health centers and clinics that actually have Wi-Fi. So my suggestion would be to say, okay, let's have a kind of general overview of what obtains on the ground. And then we can say, okay, let's pick certain districts either based on what they have already and then build on that. Let's take an example of Nyanga district, where we have Dr. Jokwiro, who is already providing telemedicine facilities in the district. He manages to hold a ward round or a clinical consultation with a nurse that is based at a clinic that's 50 kilometers away from the district hospital. So that's probably a low-hanging fruit that we can easily go and operate. We can also maybe select a mission hospital again, which could have the potential of a low-hanging fruit, in which we can infuse what is possible. So, and then we can go to a district where there is absolutely nothing. There's no connectivity. That makes life a little bit more difficult. So I would probably say that what's needed is perhaps a quick scouting to identify possible starting places and agree on what is it that needs to be done in each of the selected districts. Yes, we will have complications or possible misappropriation, but we should be able to put in place systems that make sure that will not happen.
Hi, Rudo. Thanks for joining us. Can you do a quick intro about who you are and give us some guidance on what Zimbabwe needs in terms of healthcare support?
Okay.
Hi, I'm a junior registrar at the Department of Anesthetics at the University of Zimbabwe. That's basically me. I just think we've got a lot of problems. Like I told you before, I think it makes sense to start from primary care and do something at grassroots level, because tertiary is a bit complicated and it might take longer than anticipated. But I still think we can't just complain and murmur and go on. We might as well start doing something. That's all I have to say. And thank you for inviting me.
You're welcome. We're just trying to figure out some guidance, because I'm here trying to ask for money. That's my job. If there's anything that's going to come out of this conversation, is that we have a nonprofit where I will be leading the ask from the US point of view. And every year, the US government has a lot of money it allocates to Africa, whether it's with USAID. And Dr. Sakipa, you've worked on those projects where there's funding for Africa. But once we have that money, which channels, because it's very complicated once we involve government. So I think I have to mute someone. Yeah. So we're trying to avoid having, we would rather have the doctors lead the conversation or the healthcare practitioners. And we also have Ruth here. Ruth, hi. Ruth is a Zimbabwean nurse based here in the US. You have to unmute yourself, Ruth.
Oh yeah. I see that. Okay, fine. Sorry, I just joined the meeting. I wasn't aware. I just called, so I was not aware of what's going on. But I'm a Zimbabwean nurse, and I've been around America doing these COVID cases, and so there's a lot of exposure in terms of how their health system works. So I reached out to Debbie, and I was just giving her what's going on the ground and how we can tap into that. Like they have a lot of equipment that they retire. So I see it all the time, like they're always coming up with new machines and new things like that. So my question was like, where do they put that? Where do they take that? Where do they retire those machines? How can we tap into that equipment and help Zimbabwe? Because I know there's a lot of challenges when it comes to the equipment and how the health system in Zimbabwe in general. So we are still right at the we were just talking about it like informally. So I'm very, very interested. You know, it's something that I would like to really look into also, how we can help on this end. And also the expertise that we have as nurses. We've got so many nurses, so many health professionals in America. But, you know, like in Zimbabwe, we don't really come together to really focus on one thing. Like we know Zimbabwe really needs help. But so we need to come up with an organization that can also involve the health professionals here. And then we can see how we are able to get some of the resources here to Zimbabwe and how we can do it officially, and also how it can be received in a manner that we are happy that is being distributed according to how we had anticipated. You know, there's always hurdles and red tape and corruption, and so that's what most people are so discouraged by that.
Yeah.
Okay, I hand you over, Debbie.
So yeah, does anybody else have anything they want to add before we wrap up? And at least we know who everybody is. This is a virtual meet and greet. I mean, with COVID, nobody can get together anymore. Very often we're working in our own spaces without any contact with each other. So the purpose of this talk was to discuss and to meet with each other and at least know there's a system in place and that all our efforts are being complemented by the other people there. So this is summary. Each of you say your final the thoughts on the matter, and then I'll say the thank yous to all of you.
I guess I could start. I think this is a very good initiative from what I'm understanding so far, to just try and capacitate the health sector in Zimbabwe. We have a lot of issues that we have to deal with. I mean, for example, probably half of my junior doctors that finished their housemanship last year, they're leaving the country. So issues of manpower are a big deal. We're going to end up with a situation where we may have equipment, but we don't have the doctors. Our doctors are very well trained. I'm happy to see Dr. Rulo here. They're very well trained, but there's frustration that comes with having worked for so many years and trained for so many years, and you can't live a life of a doctor. So a lot of them are leaving. It's the first thing that will always give us problems. And then the issue of equipment and consumables. I mean, starting from the basic connectivity. You know, at another hospital, we have radiology, we can do CT scan imaging, but we can't get reports. Sometimes I just send it by WhatsApp to a colleague who's in the UK, and they send me back a report. So it's good that we ideally should have a good connectivity at the hospitals. I mean, currently we communicate via WhatsApp with districts and so on, and but people are using their own data bundles and stuff like that. But if the hospitals have reliable connectivity, that will be very useful. As a surgeon, we've been fighting for, because public health has really been looking at communicable diseases, TB, COVID, HIV, and stuff like that, malaria. But we believe that as surgeons, that the surgical burden of disease needs to be addressed. We're talking about people who are suffering with a hernia and may actually die from it. They're in the district, they are booked for theater, but the theater does not have what is required. So we also think that surgical disease should be high up there in terms of public health issues. Look, I could go on and on, but I think for a start, that those are some of the issues that I feel need to be addressed.
Thank you.
Yeah, Debbie, in terms of way forward, my suggestion is that if this is an initial discussion, perhaps what we might want to do is to create a group, a listserv that creates a platform for further discussion and build on it. That's one thing, because without that, it's not possible to engage either potential donors or to engage government, because people will ask you, who are you? What are you trying to do? How can we help? Where do you want to put your inputs? And we have to accept that there are certain things that are going to be beyond our control. Dr. Sachikonye described something that we've known for several years, that this is a serious problem, that we are losing our manpower, not just doctors, but even nurses. So that needs to be addressed, and one hopes that the current goings on between the various groups and the government will come to fruition. But my belief is that while all this is going on, we can make the work of Dr. Sachikonye a little simpler by providing some of the things that he needs to do what he's doing now already. He is going to some district hospital. He gets there. He doesn't have surgical things to work with. He may not have even consumables. So let's go for the low-hanging fruit. Let's make sure that at least he has some consumables. Then we can get into maybe equipment, which is a little more sophisticated or complex, because you can't just pick a radiology machine in the US and take it to a district hospital in Zimbabwe. It won't work. So let's go for the simple things first, and make sure that we have set up a system that works to respond urgently to the needs of people that are already operational on the ground, the surgeons, the obstetricians, the pediatricians, and there's a lot that we could achieve already.
Thank you.
Okay, thank you so much. So just to wrap up, I think the suggestions to start a discussion group where we're all together is a really good idea, because then we would need to zero in on a site that we can use as our proof of concept. So while we're working on the low-hanging fruit, we need to be working on a medium to long-term project where we can assess the current situation, put together what is it that we can do in order to achieve what we want in terms of connected health or eHealth. And then we use that and give the best that we can as a model that we can then replicate elsewhere, having learned from that initial site. I think that would interest me because it's an approach that I've worked with before. For instance, in South Africa, we did a project for Ekurhuleni Metropolitan Municipality. There used to be maybe 12 or more different little municipalities, and they needed to amalgamate into one. So once they amalgamated, we were able to find and provide solutions for them to connect not only to their citizens, but all their clinics, hospitals in all the different municipalities were all connected. But they were a little bit more sophisticated in that they were able to look at different income households and work out how many of those are contributing to the tax and how many are not. And they were able to come up with a service that they could give to all those people that could not afford to pay or to access primary healthcare facilities. That's
awesome. And Rudo?
Oh, so sorry. I thank you, everyone. I came in a bit late, but I totally concur with Mr. Sachikuni, what he said, that, the sad thing is we are losing manpower. And it's so sad that I definitely know by December, maybe from the registrars, about 20-30% of us are going to be here. Today, university decided to expel registrars from Department of Obstetrics and Medicine. And, that's a foundation on top of an inflammatory situation, so it's real. The manpower situation is getting out of hand. We're losing so much, and it takes so much our seniors to train us, to make this visualize, to make things happen. Every time to have this happen at Harare Hospital, Mr. Sachikuni will concur that it takes a lot, from just water to scrub for a taste. That's like a miracle. And then if the electricity doesn't go, you're like, hooray. It's the small things, but they are so real for us. So I concur that there are things the smaller things that we also have to do that alone has to do. And the main power, the brain drain this year. So I think the health concept is quite good. But I think it's important to first identify something we can simplify as food and not overdo it. It's in
Rudo, we're having a few challenges here. But anyway, I just want to say to everybody, we're going to work really hard to see what we have in terms of if we're able to raise some money. Hi, can you hear me?
Yeah, we can hear you.
Yes.
Okay. Well, so the way forward is to see what we can bring in, either in donations of equipment, money, and so forth. And we'll reach out to you doctors who are on the ground and see what we can do. Every little bit helps. I know Ruth was on earlier on. Oh, she's back. Okay. Yeah. Sorry. Yeah, no, Ruth, I was saying, let's see what we can raise. Like, let's work as hard as we can from now on. I know you're in a hospital where if you need an organization through which to get the equipment donated, I'm available. And then we can fundraise. And once we have that, the capital and the equipment, we'll reach out to the doctors on the ground in Zimbabwe and see what we can all do together. Right?
Yeah, Deb, if I can just say that whether raising funds or equipment, it is important for the people that we are going to appeal to. They want to hear very clear statements on what is it that we are looking for. If it's looking for money, we need to be articulate on how the money is going to be used. If it's equipment, there needs to be clarity on what is it that Dr. Sachikuni needs. And then there's a linkage between what we're asking for to what he needs. And then the other thing is that we will not be able to get anything into the country unless there has been some serious discussion with the Ministry of Health, so that what is coming in is well articulated. There is connection with the customs people, because we'll not be able to get in. So it is important that we do our groundwork on what is it that's needed, and all the preparatory work is done before we start trying to get things into the country. So I think we need the likes of Dr. Sachkonye and Rudo to be able to articulate the needs on the ground that endorsed by the various actors, PMDs, DMOs, and the ministry. Without that, I think there will be problems. And I've seen it not only in Zimbabwe, but in other countries as well that I've operated in. You take things to a country, they end up rotting away without being used. So I think we need to be very clear.
I know Carrie Greer took some baby incubators to Zimbabwe and ventilators recently. She's a friend of mine. She's in Canada working in a hospital. So I'll also speak to her about her experience, and maybe that's a proof of concept that we can use. But anyway, thank you, everybody. We're running short of time. It's been a great discussion, and we all know each other. So the doctors, either we work with you through the Doctors Association, but you know where to get hold of me. And then the rest of you, like Ruth, whatever you have, we'll talk separately as well and see how we can use the nonprofits to procure all these different sort of products and things. And Dr. Sikipa, you are a senior who has the government contacts. So we'll have a private conversation as well on the steps that we need to take to make sure that it's going to be easy to facilitate any donations and any conversations with the government. So thank you, everybody. I appreciate your time, and to our doctors, we really, really appreciate the work they're doing in Zimbabwe. Thank you so much, and stay strong. All right, you take care.
Yeah. Thank you.
All right, bye-bye.
Thank you.
So Debbie,
yeah.
Debbie, I will introduce you to Cindy. She was supposed to have joined this call. She has lots of experience working with all these small hospitals in rural areas and district level, and she's used donor funding and implemented quite a number of projects. So she'll come in handy.
Thank you so much. Awesome.
Yeah.
Have a great day or evening as it is in Zimbabwe.
Okay.
You too. Thank you.
All right. Bye-bye.
Bye.
Bye.
Thank you.